the Task Force ETIN for Emerging Technologies and Innovations in Neurosurgery. My name is Nikolai Gavrovsky, and I'm pleased to lead this webinar. As you know, at the end of last year, the European Association of Neurosurgical Societies has established this task force. We are mainly dedicated to present new technologies, innovations, and things that are related to the future of neurosurgery. I'm very glad that we have started very well with our first webinar on the 8th of March. We had as an invited speaker Professor Kasabov from New Zealand, who presented us the topic neuroinformatics, neural networks, neurocomputers, and some applications in neurosurgery. So today we shall continue with our second webinar. But before that, I would like to share with you a very good news that we had from today. So in the month of February, ETIN has made an application to the European Commission to become a partner in the Health Technology Assessment Stakeholder Network. So I'm very glad to share with you that today in the afternoon, we received a letter from the European Commission, from the Directorate General for Health and Food Safety, and I will read the most important for us sentence. I'm pleased to inform you that the Commission has decided to appoint your organization as a member of the Health Technology Assessment Stakeholders Network. So I'm really pleased to share with you this recognition for our efforts. From now, we will be official partners of the European Commission in the difficult task to assess the new technologies in healthcare. But let's go to our work. Before that, I would like to thanks for this, because this was a teamwork. I would like to thanks for the efforts to submit this successful application to the Office of the European Association of Neurosurgical Societies, and to Andreas Demetriades, who gave the idea for this direction of development of ENS and ETIN. But now let's go back to our work and our webinar. Today we have two invited speakers. The first one is Stefan Wilsmeyer, who is founder and CEO of BrainLab. He will talk today about how digital technologies can shape the future of neurosurgery. And our second invited speaker is Jorge Presa from Cybersurgery, Spain. He will talk about the present and future of robotics in spinal surgery. So I think that these are very interesting, hot topics, and it will be very interesting for all of us. I will remind you that you can ask your questions via the question and answer box. You can find it in the bottom of your screen. And after the presentations, we will have brief discussions, and some of your questions will be asked to the invited speakers. So I will give the floor to Stefan now to start his presentation, asking him before that to present himself very briefly. Stefan?
Okay, so first of all, thank you for the opportunity to present my thoughts in how technology can really contribute to neurosurgery. So I started BrainLab more than 30 years ago, at a time when a neurosurgeon that needed software wasn't a good neurosurgeon. Today, neurosurgeons doing certain types of procedure without the proper software may be considered not good neurosurgeons. So fortunately, basically times have changed, and I also think that the role that technology can play in neurosurgery will continue to evolve, and with basically all the technologies in basically whether it is robotics, cloud computing, basically the latest generation of AI, etc. The opportunities are really tremendous to continue to evolve surgery even faster. And I think that medicine in general is a very conservative field with basically very slow uptake on technology. However, neurosurgeons have always been at the forefront of medical technology. Neurosurgeons have been the first to introduce and fully leverage and use CT scanners, MRI scanners, microscopes, etc. And so for that reason, we also believe that neurosurgery is going to be the discipline to be looked at first, to also implement some of the other promising technologies first. But I also believe that sometimes what is technically possible may no longer be the limiting factor, but in fact, there is a number of other factors that also need to be considered. And, I look forward to taking you on a journey on, how different technologies can all play together.
It will be our pleasure. And thank you very much for accepting to join us tonight and to share your vision for the future of neurosurgery. So please, you can share your screen and start your presentation.
Okay, so now you should be able to see my screen. And essentially, when you look at neurosurgery, then one of the technologies that is maybe most broadly implemented is basically navigation. And I think that whenever talking about navigation, the analogy that comes to basically most people's mind is really using basically Google Maps, and which is of course characterized by having some form of tracking and having a mapping service. But if you really analyze what makes Google so successful, and I think there's also an analogy in the area of surgery, then it is the availability of a broad range of statistical layers, which number one contain topography, but also traffic flows, public transportation, and a range of additional information. And if you then look at what else Google is offering, then there's augmented street view, which is incorporating video. And when you pull up your phone to scan a street, it will tell you and label which direction to go, where to turn, and it actually can recognize some of the buildings. And the reason why augmented street view works is because it's linked to navigation, which is linked to the maps, which is linked to the statistical layer. Every time you're pulling out your phone, you're basically feeding that statistical layer and the other way around. And just a combination of the four, which is really what has made Google so successful and unique. And in a way, if you look at modern navigation from various vendors, you'll find basically a similar analogy in neurosurgery. So, of course, there is, tracking, and there is basically then an anatomical map. But, you all use microscopes, which is, video information. And basically, it's just a combination between the tracking and the video that basically, establishes like this vector. But also at the end of the day, every time you operate, in theory, you're also contributing basically to a statistical, data set. And, I want to put a bit more focus and zoom into basically, how that will evolve and why this is like really important and what the potential and, outlook of that is. So if we basically zoom in on the first component on the, upper left hand corner of the sketch, basically, we need, first of all, tracking. And in the OR, there may be, a growing number of different tracking capabilities. You may have cameras and microscopes and video camera, 2D cameras, and there is a number of different sensors that are now emerging. And at the end of the day, all of them need to somehow be combined in some sort of swarm intelligence. If you really want to realize every single step of surgery and everything that's happening, then beyond just basically picking up a pointer, sticking it into the patient's brain and seeing where you are, then I think it's really piecing together, all these different information components to a comprehensive system. So going back to our analogy of Google Maps. So at the end of the day, we don't want to just recognize 1 or 3 or 5 landmarks or components. There's now a number of companies and also academic groups that can map 1 or 3 or 5 different structures in the brain using AI, quite precisely. I think the opportunity is to find an ability to map every single pixel, every single voxel to a abstract model. Despite all patients being different, it would still be able, a good idea to find one common denominator to bring it all together. Similar to using maybe an OCR software to take a scanned-in document to make a document computer searchable and readable, we want to make the patient's anatomy computer readable and identify every single structure. And if you do so, on the one hand, you may get basically prettier diagnostic images because we now can extract the semantic understanding. We can peel away the different layers of anatomy, like the different layers of an onion. And basically, what means that there's, better and nicer images also means that now all of a sudden you can map everything to this one universal patient. So basically, this is a slide extracted from a work from the university in Amsterdam. But the idea of looking at a resectability map, for example, requires that we have one framework that allows us to map even patients despite of all the anatomical differences, all at the end onto one patient. So what you see here is red is non-resectable and green is resectable for a glioma, by looking at a large number of patients from before and after surgery, for example. So that's why I believe that a lot of those future mapping concepts require this one model. But when we look at mapping that model and creating this anatomical model, as you see here, and having every single pixel, every single voxel labeled and creating a three-dimensional model, the problem is the anatomy is changing during surgery. So what if you're halfway into surgery? Then of course things would have shifted around. So what I think the future really requires is the ability to progressively update that model. So what you see here is a finite element model by knowing the elastic properties of every single cube here in this model, and even with limited information from the surface, having the ability to then update or progressively update what that model would look like basically halfway into surgery after you've started resecting the tumor. Initially, we thought that just having a simple morphing of anatomy is going to be sufficient, but we realized that the problem is you have, the ventricles are collapsing, and basically just simply morphing two data sets will not represent anything that's anatomically, correct. And you need to also have a model that basically, models the true anatomy and the elastic behavior. And I believe that this is one of the great frontiers. Right now, this calculation takes 10 minutes, and we can only use an intraoperative CT to update that. In the future, ideally use ultrasound, or even better, the images from a surgical microscope. So if you can continuously measure, how the surface is changing as you progress in surgery, and if you'll be able to update in real time how your anatomy changes, you get a, continuously updated model. And this is, by the way, I think the holy grail to bring image-guided surgery also to the abdominal applications. For example, how can you turn a Da Vinci robot into some device that really understands the tissue it is cutting through? That's basically the technology that basically is required, and there's I think globally a number of groups working towards that. And the concept is also illustrated here by having basically superposition of a preoperative and postoperative X-ray, but MRI, but we have also taken basically intraoperative CTs to basically simulate what a intraoperative MRI would look like. So I think in the future, if you'll be able to do that by continuously feeding the information from the microscope, maybe to also amend it by basically an ultrasound device, then you would get a progressively updated model of the brain. And if this is effortless, and that would certainly be, I think, quite interesting. And then, of course, there is basically navigation that you're all familiar with for tracking, and then fundamentally, also microscope images and microscope overlays. And you all have seen that, but basically think of that as knowing the anatomical vector, similar to basically a car, and with the effort of creating autonomous driving cars that basically also can recognize an intersection of a road. This is not just based by recognizing the buildings, but also having GPS coordinates. And by having a common framework to know what is the anatomical vector you're looking at, you could actually look at a 1,000 of surgical videos, 1,000 different patients, and you can sort it by the anatomical vector that you're looking at, and basically say, for this particular position, this cranial nerve, what would that look like from basically 1,000 different patients? And that is one of the opportunities by basically using this concept of mapping it all onto a standardized patient. And then there is, of course, if you look at digital transformation, the digital world, the ability to basically map the digital world into the physical world using basically mixed reality applications. And I will, elaborate on that a little bit more, later on. And then, of course, there is robotics, but I'm basically sparing the topic because that's going to be covered by the next speaker. But I think there is right now a number of different robotic solutions, and I think that will also further, streamline, some of the procedures. And but I think that sometimes I feel that robotics in surgery is sometimes a hammer looking for a nail, and I think we need to be cautious to basically make sure that we're really solving a real surgical problem, and that basically, using a robot is really improving or solving a tangible problem. And then, of course, there is more imaging and basically a number of different imaging devices. And I think the idea of taking intraoperative updates of images is also becoming increasingly important. But, I just mentioned that there also needs to be innovation in this field, new MRI sequences, basically, CT-based CT reconstructions from MRIs, shadow imaging. I think there's also going to be future innovation in imaging, but I think probably I'm not the right speaker for that. And I think there's probably a broad range of opportunities in that space. I want to more look in and zoom in onto data that's being generated during surgery and how data will drive the future of neurosurgery. And, I've just used here obviously not neurosurgical patient, but I think it's also an example of how data is being collected throughout the treatment journey. And you can look at here, basically, patient data that's being generated during radiology. You have data, genetic data. You may have data that's being generated during a tumor board meeting, during surgery, during basically chemotherapy treatment, maybe as, patient prompts and patient data that is being generated, and then of course during radiation oncology. And basically this all together is data that's being used for as in primary use for patients. And I think the huge opportunity is going to be how that data would be used for secondary use. So how we can use data of cancer patients today to basically cure and improve cancer treatments for our children and grandchildren. This is, I think, the big opportunities. And, I think it's also, I can't, be speaking at the ENS, panel without also mentioning that the EU Commission has basically proposed the European Health Data Space as an initiative, and basically which I think is especially targeting this area, like, how can we generate more data and how we can have a framework that would basically allow how that data is being used, for secondary purposes. And so the European Health Data Space is based on the idea of basically every group that has data has to register that with some central body. And then by anybody, interested in having access to that same data has to share it with a centralized government body to then have that data being basically used for, shared with that group. The way this is written is, I think, basically, concerning in a number of different ways, because as a researcher, you may be having accumulated some data. However, some competing group basically asks you to give them that data, then that is to be shared. I know there is some pushback, but and some discussion going on at the council basically level, but I think there's no final conclusion. So let's hope that basically, actually that European Health Data Space will drive and enable a better use of secondary use of the data, but that at the end of the day, it doesn't kill research and innovation by basically forcing every research group to share data before it's being published. But I think the current proposals are to at least have a grace period until data is being published, and then it is to be shared. So most of it is modeled by what maybe Finland is doing with it with its data, which I think has been collected since the 50s and is probably an example in many interesting ways of how rare diseases or rare side effects of medications may be identified. But I mean, yeah, this is like obviously something that will define how Europe and how also potentially the ENS will position in this whole data space. But I want to basically highlight a couple of different opportunities and why I think it's also worthwhile to fight for the right framework for using that data. So first of all, I think that it's important to put patient consent into the center, and that basically we must find a way of how patients can control data. There's an ongoing debate on whether the data is really owned by the patient or by the researcher collecting the data, or the hospital, or the scientific society that may be collecting the data, or the government even, as recently proposed. So in the European Commission's proposal, the government would decide who would basically get access to the data for secondary use, and we propose that really the patient must be put in the center to define how data is being shared with physicians, with fundamental research, with industry, what type of data, and through which application. But I'm hopeful that basically the Commission will get that right at the end. The main dilemma, though, is that most of the data is unstructured, and even if somebody would hand me all the hard disks from basically hospitals, that data, to the largest extent, is basically just not really useful because it is unstructured. And basically, how did we discover that? This is, for example, what the German, cancer registry looks like. It's still, in paper form. So Germany is probably the worst country, the worst example within Europe. But, when talking about when there's a sole push for digital transformation, it's also important to keep that in mind. And essentially, almost a decade ago, we have been engaged with AANS to create a SRS registry. And that was basically our first introduction to the dilemma of how you really get data in a way that you can compare that. Because, you may say that this tumor was given 20 gray. However, the question is, do you give it to the GTV or the CTV? Do you add 1 or 2 millimeter margin to create a PTV? Do you cover this PTV 100% with your 20 gray, or only 99% of that PTV, or 95%? And what's the maximum dose? Is it basically 100%, 108%, or is it unlimited? So with a Gamma knife, you can easily get, if you're prescribing to 50% of your dose, you get basically up to 400% of the dose. So even standardizing what is a prescription is, I think, basically not trivial. So we propose to look into the whole distribution of dose inside the tumor, but also to look at, your prescription dose isn't what you say it is, but basically everything that's covering the 99% of the CTV is, maybe your prescription dose. And and some of the data and there's about 4,000 papers that have been published on brain mets over the last 60 years, and basically it's still difficult to extract, even in a meta-analysis, some conclusive data on basically thresholds and what causes radiation necrosis and what is maybe threshold doses for, I don't know, vascular structures, etc. And so I think that only with basically highly granular and highly curated data, you can achieve that. For example, what's the dose to the brainstem? You need to almost like standardize or normalize, how we define the brainstem. So otherwise you're comparing, apples and oranges. So we looked at that, but however, we realized that this is, in German, but, I think you get the idea. This is what a radiological report normally looks like. And so it's all in text and difficult to understand. However, what you would like to, be a report to look like is something like this, where you see longitudinal information about the primary lesion, but also basically any secondary findings, so that you can actually quantify what should happen. And so I think tumor progression was basically a criteria to basically abandon the therapy. So basically that patient should have received an alternative therapy, 6 months earlier. but by, shorter and shorter follow-up intervals, it's like sometimes difficult to capture what the change really is. So I think there need to be a way of finding structured information in a much, better way. And so, we have basically looked at a method for, this is, for example, not a neurosurgical application, but I think sometimes looking at an application outside is sometimes helpful. So here's a primary diagnosis following a catalog of different criteria, and secondary diagnosis that is also being followed. However, if you're looking at a brain metastasis, having better information about the primary diagnosis and to which extent this is progressive may also be helpful. And if two radiologists look at the same patient, you sometimes can't even see if they've seen the same thing. And so basically this is our concept on how basically you should standardize diagnostic reports. And in fact, here, this is, for example, a report for COVID patients that has been standardized across Germany as part of a national university, medicine network, where all 38 university hospitals have aggregated, I think, 15,000, COVID patients and extracted basically data that's being shared. And I think that looking at basically neurosurgery, where case numbers are much lower, I think having a high granularity and, collecting data in a registry, I think would be a very important, topic. And there is already, other, reports that I think we've created and we've partially, rolled out in different regions of the world. And then, of course, it's also important to capture basically forms and also, prompts. So we've worked, for example, with scientific organizations in the area of spine, of creating, spine registries and different areas, and basically generating forms is really complicated. And basically, I think that it would be important to create everything in FHIR and have basically better clinical data entry so that you get clinical, symptoms and the granularity that would be required for basically more rigorous analysis other than free float texts. And then, of course, there's the need of using, AI, and basically image data also should be part of registries. For example, you can automatically, recognize basic vertebrae in the spine. You can use it from 2D to 3D, measure the position automatically, plan perfect positions of pedicles, and basically also compare what an actual position, is compared to what was originally planned. And, for example, this is in orthopedics, and where basically software can automatically quantify and measure, what exactly the position of a hip implant is. And I'm mentioning that as an example because orthopedics is the area that's the oldest subspecialty when it comes to registries. Some of them go back, 15, 20 years, like the Australian registry, I think is the oldest, registry. And there is, believe it or not, 42 registries for knees and hips globally, mostly done by, small companies of just a handful of employees, hardly scaling on a national level and certainly not on an international level. So I think that finding better ways of capturing data in a structured way, I think is really, the way forward in different areas of medicine. And basically, so therefore investing in the structure is important, that those registries become more meaningful compared to what is being basically captured today. And then, of course, if you have data, like how is it being deployed in operating rooms? And I want to also introduce an idea here. So basically in ORs, you have all kinds of screens, and normally to deploy a new piece of technology in an operating room means you have another cart that you're wheeling into the room. So, but this is basically not sustainable, and basically from a sustainability point of view, but it's also hard to implement. And so basically, what if you could hijack all those, existing, screens in a more simple, way? And so, what we are proposing is basically, technologies and layers that, in essence, would basically allow you to, connect maybe run through a video signal, but basically then stream it somewhere else, but then have software running maybe on a central server that you can basically place on that same screen. such a framework would also be open for startups. It would foster innovation. It would allow university homegrown applications. It could be basically things running in a lab, but being brought, into the OR. I think it's a huge innovation hurdle in basically surgery in general. How can you actually get some content that may be running in your biomedical, lab or in some startup, be deployed in the operating room in a way without disrupting basically the flow of the rest. And then, of course, those tools would also need to have then the right infrastructure and processing power to do AI on detecting landmarks, instruments, or events. And basically, there's a number of academic groups of recognizing those instruments and events, but this is also technically challenging and complicated from a patient privacy point of view. I think that getting a contract with a hospital and getting that data basically shared is really difficult, and that's also maybe an area where we need to almost like reinvent how industry can work with basically scientific organizations like the EANS to find a vehicle on how basically we can get actually live data from the OR. For us as a company to solve that problem is we started a joint venture in China where it's much easier to get basic access to video data, and also you get some good AI software engineers. But I believe that it definitely would be a shame if we wouldn't be able to also use that in Europe. And the idea is that from those videos that you would ideally be able to label all the different steps of surgical phases and recognize where those steps are. And if you basically go and basically map that step and visualize it along a particular timeline, then by comparing different procedures, you find outliers, and you might be able to predict what the exact duration of a procedure could be. So you could, as a first benefit, calculate what the expected time of arrival is when you are expected to end the procedure, to notify follow-on surgeries and basically other things around that. But also it will allow you to record very granular information. So since capturing and getting this basically surgical data is maybe difficult, we have actually started working with synthetic data. So what you see here is tracking maybe the instruments on a surgical tray. However, all those were trained by not real patient data, but in fact data that was generated by just a computer drawing or a CAD system, where we're able to recognize those different instruments independent from even having manufactured those instruments. And that has basically more or less triggered the idea or concept that maybe we need a metaverse, not in the Mark Zuckerberg definition, but basically can there be a neurosurgical metaverse, almost like the parallel world of neurosurgery. So the same way of how we are able to maybe have a digital copy of the patient, can there be a digital copy of the workflow? And for example, if you look at knee procedures, and this is like maybe also owed to the fact that basically brain surgery is a bit more complicated. So we've started to build mock-ups for knee surgery. On the left hand, you'll find the classical procedure guide that you find in textbooks, and on the right hand side is the digital component. And we've created basically a virtual patient that has full elasticity, where you can insert the retractors, open up basically the knee, you can bend it, you can change the camera angle. So we have basically experimented with something that's not just a video, but this is like fully interactive and could be played by multiple people at the same time over a, say, multiplayer collaboration platform. And you can now basically insert, you can turn it, you can pick an instrument, insert that, and do complete virtual surgery. And now if you look at the renderings, they are photorealistic and at a level of quality that you could use those renderings to train AI algorithm. So what if one of the knobs has changed? What if the draping system has changed or some other component? It would essentially mean that you have to almost like throw away 10 years of video data that you've collected and labeled and start all over. So by having a digital metaverse to generate all of that, we can generate different patient anatomy, different instruments, different draping system, table systems, C-arms, different lighting situation, different camera angles. And if anything changes, we overnight just retrain our algorithms, and that would work as well. So that will also open the door to training and education. So what you see here is a simulator that we have generated for NASA to train astronauts for deep space missions on how ultrasound works. So you see here different objects. So this is going up on one of the next SpaceX missions, and basically here we'll be able to then track the learn how ultrasound works, and we've created basically metaverses in different other ways, like here, for example, for spinal surgery, where you would be able to see on the right-hand side, how you put in a screwdriver, but you see that, underneath there's a whole framework of basically just, all the elements of a vector of a patient, including X-ray, etc. So what we have done here is, for example, tried a spinal surgery, mock-up where you can, or a model where you can select which instrument you use, whether you use, pressure tools or basically a drill guide. And basically you use here, for example, a drill guide, but we've also used, what if you basically were to deploy a mixed reality headset, like a, Magic Leap, HoloLens, or whatever, where now you use, for example, an awl and basically in a hammer in spinal surgery, and basically then basically trying to simulate what is basically the consequence of if you like move the vertebra, and to which extent does it move back in the same position if you now screw in this. And this is also working in a mixed reality rather than a virtual reality background, so where you can put it on your kitchen table and look at it from different angles, and basically find a complete virtual training environment where you can still continue to work with instruments, and here's maybe easier to see how we can use a hammer and then look at what the displacement really is. So I think that what you can see here with this headset, that now all of a sudden you have a device that creates a good combination between the digital and the physical world. And after you have put in all the different screws, you can actually grab it and look at it and see what is the difference between the intended and the actual position based on the tools you've used. And then, of course, the idea is that this is like also then expanding into surgery, that you'll be able to capture through a headset surgery. You could see basically then the virtual anatomy projected. You will be able to then basically navigate instruments. You basically see then just injected this, and there's several groups and players actively involved in that. And this is in essence my my maybe introduction of basically this metaverse. And I think all together I try to explain how basically this idea of a patient model and tracking and this digital model is basically has to be linked to a digital model of the workflow. Because if you basically have an AI algorithm that basically recognizes how you set a suture, that may be great, but if you don't know what is the continuum of the 27 steps of surgery, and this is now step 17A, and now the next is 18, maybe A and B, and here's where it branches off, then it becomes virtually useless. And that basically I think as you have this metaverse, you can use it to continue to train AI algorithms that will detect when a particular step has been completed, which of course then feeds data into our data infrastructure. And we need more data in a very, say, highly specialized clinical subspecialties such as neurosurgery, so that we basically can derive better information for for basically having decision support and basically also deploying a new concept of training. So I think what I try to show is that training and simulation and planning and actually execution are all going to eventually merge, and that will also be the vehicle to basically accelerate learning, to globally deploy new concepts. If there's a new concept, a new idea, then it can be immediately rolled out worldwide, and it also creates a collaboration platform for industry to basically also introduce a new technology in a more seamless way and allow surgeons to experience and test that technology without going straight to the patient, but also allowing basically playing or experimenting with a new technology basically in an environment that is essentially without putting harm on the patient. In general, in surgery, I believe that for the last 30 years, the challenge of technology was how can you provide better outcomes and provide those outcomes basically ideally at a lower cost, and ideally both better outcomes and a lower cost. I think that looking at the global healthcare economy, that is going to shift a little bit. I think the challenge of the next 20 years will be to provide sometimes a treatment at all with limited resources. So how can treatments require less resources? And that basically means accelerating the existing resources in the learning, enabling second-year residents to do things that normally they'll be able to do in the fourth year, to have basically additional assistance systems, to have basically accelerated learning, to have expert system, and basically also telepresence solutions. And if you look at Germany, and this is probably pictured throughout many parts of Europe, 20% of the hospital beds are sometimes can't be filled because there's like a shortage of staff. You have more staff turnover. It will become more difficult to get even scrub nurses that basically are fully trained on what is the next instrument they should hand. And so I think that in my opinion also a lot of the technologies or concepts that I introduced will also support this whole dilemma of basically having a better way of managing maybe limited resources, less experienced resources, to still basically be able to maintain neurosurgery at basically a level that is accessible today. And thank you for allowing me to share my thinking and my vision of the role of technology, and look forward to your questions.
Thank you very much, Stefan. It was a very interesting presentation. For sure, when I go back 15 or 20 years ago, we operated in a completely different manner. And I'm sure that in the next 15 or 20 years, everything could change tremendously. And not only concerning surgery itself, but also the way we learn surgery. So we will have completely different learning curve thanks to technologies that similar to the technologies that you have presented. I will suggest, because the second topic is very closely related to this, to your presentation, and I think that it will be better for us to have the discussion at the end of the presentation. So I will ask the second speaker to present his speech, but before all to present briefly himself. Jorge, can you introduce briefly yourself before starting your presentation?
Okay. Good afternoon. Thank you, all of you, for inviting us to present our ideas about this interesting topic. I am Jorge Presa, the CEO of Cybersurgery, a new startup related with the robotic platform for spine. So I'm going to share my screen. Here we go. Okay. Honestly, Nikolai, how much time do we have?
You have 10 to 15 minutes.
10 minutes. Okay, yeah. I'm going to speed up a little bit. Okay, present and future of spinal robotics. Just a brief overview in industry from the beginning, from the scratch to industry 4.0, 250 years. And obviously in healthcare, we have advanced in database, diagnosis, treatment, but everything is speeding up. So for, sorry about that. Medical image is 150 years, the history. For computer and navigation, 100 years. Surgical robotics, the history is only 40 years, and in spinal surgery, 20 years. This is important in order to see or to realize how fast is going this market. There are several samples about brain biopsy, hip arthroplasty, later laparoscopy, radiosurgery, also brain biopsy. This is a great example of intuitive and how they move from that specialist to urology, for example. Other examples about robotics, catheter compatible with MRI. In this case, like the previous speaker, Stefan, this is an example of brain lab, radiotherapy, knee replacement, the famous Mako for knee and hip, and also microsurgery, dental. So the global idea that I wanted to tell is that there are hundreds of robots for different kind of application. So robotic has come to stay here. I mean that it's obvious that robotic slowly but step by step is going to be in our operating rooms. So talking about robotics and coming back regarding our previous speaker, Stefan, optical tracking implies optical navigation. Okay. Optical navigation, cameras, and we locate some references on the instrument and on the patient. Okay. So we know it's like our eyes. We know where is the patient, where is the instrument, and we can correlate both of them. So this allows us navigation systems that is very common, and is something that you use currently. The next step was to join optical navigation with industrial robots, not specific robotics, okay? And was the beginning of optical robotics. So in this case, we have the same cameras, we have the robot, and we locate the references on the robot and on the patient. This is very useful because it helps us for holding the instruments. So there are two problems, holding the instrument and at the same time that we need to look at the screen at the same time that we are performing the surgery. So with the robot, that system is going to hold your instruments. There are many companies and the market is growing quite fast. Right here we have 10 examples. Not all of them are certified, but several examples. So the next step has been augmented reality due to the technology. Augmented reality, at the beginning, the application was augmented reality plus external optical tracking. So there are references on the glasses and on the patient. So right now we have the information in the glasses, but the accuracy is given by the optical tracking system. The next step that is very close, and I have seen a couple of companies that is working hard on this field, is optical navigation without external tracking. So this system uses the internal cameras to locate. Honestly, we believe that is not so accurate, but is the beginning. So probably for lumbar area could be useful, but not for the rest of the spine. And talking about the future, not even the future, in some cases, is the present technology. What we have seen is that technology is pushing hard two areas: accuracy, ergonomics, seamless procedure. So it's going to improve how you perform the surgery. but the other part is intelligence, is related with artificial intelligence. So in this case, we could talk about new technologies, haptic tracking. What is haptic tracking? And it implies haptic robotics. Instead of using cameras and references on the robot or on the patient, we get rid of these cameras. How? Why don't we connect directly our robot with the patient? With a very accurate tracking system. Imagine that we were blind. Instead of looking with the cameras to one hand and to the other hand, we can connect two hands, or we can use both hands to know where is any part that we want to hold with the other hand. So we remove the cameras and we connect directly with a tracking system that is much more accurate. We are not affected by occlusions. And finally, something that is very important for the future functionalities is the higher control loop frequency. I will explain later. So this is one example of our robot and the tracking system. As you can realize, the tracking system is connected with the patient and is pointing to the trajectory that has been already planned. In this case, Dr. Sampron moves the cadaver, and as you can see, the robot at the position is real-time tracking. This is very important due to the reading of the patient, any kind of movement. So it's real-time, it's more accurate, and there is no cameras. So the next step is, okay, all of the robots are focused on pedicle screws placement. Why don't we go a step further for future applications? The future applications are going to be bone cutting, bone resection, other procedures, guidance. It's like a robot only for pedicle screws. Obviously, that's the tip of the iceberg, it's just the beginning, but we should use this kind of robot for future applications. So it's something that we are working currently, and we are also performing some surgeries, in this case, in some prototypes for bone cutting and tumor ablation guiding. So other future technologies are, has been mentioned before, real image guidance and ultrasound. This is very important, although has to be, in some cases, open procedures, open surgeries. But the advantage is that is less X-ray exposure. So imagine that it would be an open surgery. In that case, with a camera, we could be like registering all of the time. So the tracking could be the registration system at the same time. But as I mentioned, the drawback is that it has to be an open surgery. Finally, we have been talking about not only improving your, I don't know, how you perform the surgery, also the intelligence. In order to improve the intelligence, I'm not going to tell many things about this due to the previous presentation, but the key factor is machine learning with artificial intelligence in two areas. The first area is assist for screw placement, automatic screw placement. If you do the planning and there are something that the system realizes that it's not working properly, has to tell you, come on, you are pointing to something that shouldn't be. So it's very important. And the other one is sagittal balance. If you have a robot that you insert the screws in a very accurate way, you know exactly where the screws are placed. And if you know that, and also the sagittal balance that you want, the system can tell you how you should bend the rods in order to get what you have already planned. So talking about the future and these kind of things, imagine that when we began with a telephone, an old telephone, 200 years ago, and this is a fixed telephone, and imagine a mobile phone, the first mobile phone was 30 years ago. So honestly, it's not the future, it's our present. So I would like to point out that these kind of technologies are growing so fast and could help us so fast that the limit is not technology. The limit is that sometimes we are in a very conservative market. So it takes time to get used to these technologies, but the technology could help us as in other specialties. So thank you very much for your attention. And if you have any questions, please let us know.
Thank you very much, Jorge, for this presentation. It was a very brief but nice overview of these new technologies. Only a few years ago, talking about robotics in neurosurgery was something very, I would say, exotic. But nowadays, in more and more operating theaters, we see this type of devices, and they are changing completely our workflow. And as both of you mentioned, the learning curve. So now you can have a much more secure and precise surgery since the very first, without having a lot of experience as a surgeon. So these tools are very important from this point of view. And probably, as Stefan mentioned, they will make possible for us to produce faster, better surgeons. And this is quite important. So we go to our last part. This is the discussion part. I see that we have some questions here. And the first one is for Stefan. And it is, how is BrainLab is going to integrate functional data from tumor surgery in imaging?
So, first of all, functional data is obviously coming from functional imaging, and this is something that we have really put a lot of effort, and probably have been one of the first to even introduce that capability. And I would say that basically today we are, and what is very important is that this is also distortion corrected to be integrated. I believe that there's now, or continues to be a lot of innovation in the area of functional data, whether it is basically different imaging, concepts, different basic ways of how, fiber tracking can be, evolved, and then of course, basically, other, functional information data points from intraoperative, basically. Monitoring and so on that all contribute to basically more or less a functional framework. But I believe that especially all the efforts around brain-machine interfaces for us as a technology provider have almost like put more of a spotlight onto that. And I believe that as a neurosurgical technology companies, it will become more important to interface and work even more effectively with basically general brain research. So I think that neurosurgery and maybe brain and fundamental brain research hasn't been sufficiently maybe connected or interconnected, at least from a technology point of view. And I do believe that beyond making sure that whatever innovation comes from basically different other fields will remain to be integrated into navigation and those data models, that basically there's also definitely a stronger interface with basic fundamental brain research, because I think there's more of an overlap of how you use, for example, navigated TMS and treatment of depression, and how we can even recognize and diagnose that, how we can have maybe voice markers and patient prompts, etc. So we're seeing more and more areas where there's technology being shared between basically different behavioral issues, but also broader brain research. And this is in fact one of also the interesting opportunities as more brain machine interface technologies may emerge.
Thank you very much, Stefan. I see that we have questions from Enrico. Enrico, you have the floor.
Yes. First of all, allow me to thank both the speakers for their very interesting and at the same time complementary presentations. And we had a very nice overview on what we have today available, what is the next future. And I do have a question to Jorge, because you quickly mentioned about having robotic arms doing more than just holding a pre-planned trajectory. So you were mentioning about bone decompression.
Yes.
Where we are now, what is actually making us missing more active and proactive robotic arms?
Okay. To be honest, in my opinion, but Stefan knows more than us, optical tracking, the feedback that it gives to the system is a technological point of view, if 20 milliseconds, something like that. With our, for example, haptic tracking, you have the feedback every 1 millisecond. So it allows you a feedback like Da Vinci of 1 kilohertz. So it's faster. The moment that instead of guiding you for inserting a tool, guiding a drill that is a high-speed drill inside the body of the patient, wow, it's for certification, is a great challenge. It's a great challenge, but technologically, it can be done. So already we have done, but the clinical trials that we have done, the intended use has been only for pedicle screws. It's like a small startup. We want to be in the market as soon as possible, but honestly, the future has to be in that way. What can be done in knee, for example? So we believe that in the near future, although the spine is moving, is not fixed like the knee, it could be done. So the other thing is that, as I mentioned, it's a very conservative market. So people that instead of drill the robot by itself, that it could be done, the beginning is going to be a collaboration between the surgeon and the robot. So what we have done is that you hold the drill and the robot is going to limit you in order to go deeper or farther, but you are going to still hold the drill, because probably you are not going to feel comfortable if the robot is going to do all the task by itself. Okay?
Thank you. And I see that there are, before going to Marcel and Nicolas, there is a question from Chirag Solansky. I don't know who will answer, but both of you probably may help to answer to this question. If infrared scanning and spectrometry, is there a possibility to using in neurosurgery? Infrared scanning and spectrometry.
Okay, so I guess this is maybe more a question to me, and I have to say that I'm probably not a big expert in that area, but I would say that there's going to be probably more information for contributing to a patient model than basically just CT and MRI scans. And I think that especially photonics and basically different other optical imaging concepts, different light frequencies, etc. Are also going to be, I think, important. I think the future microscopes we'll see in 3D, and basically along with that will be that you don't have to switch between different imaging modes, but they'll be virtually, from the perspective of the surgeon, just be all together, and they will all add to a more comprehensive model. Also, maybe adding to the question before, about robotics, I believe that it is important that there will be more capabilities that robots will be able to do once you have really a true introduction of haptics. And basically this will probably be a bit of a bottleneck. So you need to have more haptic capabilities that basically you'll be able to introduce, so that a robot, when it's getting through a bone, that it will recognize it, that will be, when the say the feedback is changing, or essentially the elasticity of something, that it basically has superhuman senses that it will basically give the surgeon. But I think that one of the challenges in neurosurgery is, from my perspective, neurosurgeons are so good that it's hard to really identify what exact task in the overall range of treatments would really be radically different with a true patient benefit if that particular step would be basically executed by a robot. And there is some very limited or select basically capabilities. In general, I would agree with basically my other colleague speaker, that basically the way of how you track will be different. But I think that at the end it will be a combination of different sensors. It will be haptic sensors. It will be basically it will be basically 2D cameras that will capture something. It will be also other light frequencies. So there will be at the end a number of different tracking technologies that all will work together.
Thanks a lot, Stefan. Nico and Marcel, extremely concise,
hello.
please.
Yeah, hello. Thank you very much for your presentation. I have a burning question coming from the neurosurgical community metaverse, and I don't know if you're aware that exists already and is in the social media. They are asking futuristic questions. For example, we all admire very much your work, Stefan, and also all the contribution of you and your company have made to already shape neurosurgery. And one question is, you have worked a lot on radiosurgery, for example. And in radiosurgery, the model is exactly that. The surgeon is doing the important thing, the inspirational part, the creative part, which is planning the treatment, or the surgical team, and a machine is performing the surgery. So do you see in the near future something like that in brain surgery, open brain surgery, or delegating on the robot or to a machine, for example, the craniotomy, or do you see that is more belonging to science fiction? Thank you.
I think that, thank you, on the analogy with radiosurgery. And, I personally think that one of the next interesting opportunities is the use of basically focused ultrasound and, histotripsy, for example, where in essence, you'll be able to make a cut inside, the brain without basically opening the skull, conceptually, where basically you could make, in the ventricles, maybe a small cut, or where you could basically, have maybe at the proximal part of the tumor, basically, just a few cuts that where you basically during surgery may not be sure if things have shifted around, where the end, from imaging may be, where basically before you open the skull, you basically make a few three-dimensional cuts, and then you basically just come in and remove the tumor that is actually already cut loose, from behind, and you work yourself to the tumor and then can maybe remove it or block. And so I think there would be other concepts that may assist that, very similar to radiosurgery, but basically using other non-invasive, methods. There's going to be probably, also, nanobots that may basically, like small robots that could be injected through the bloodstream and could basically more or less sit in the tumor, and basically the tumor continues to grow like little Pac-Mans, basically eat up the tumor, and so on. So, I think that all those things may sound like, science fiction, but I don't think that we're as far away as basically we have thought. I think that if you look at all the brain-machine interfaces, I think that this is basically already, much more or much further than basically most people really think. So, the idea of basically using a vascular injection of a stent-like chip into the brain that can be placed in certain areas is probably very similar to what maybe some of the some people in our society, are afraid of, except it's not coming from Microsoft and not part of the basically, corona vaccination. But basically, I think in theory, the implantation of chips, I think we're talking about 5 or 10 years away. And I think that basically the role of neurosurgery, I think, is going to be potentially changing with some of those technologies, but also maybe potentially the ethical and moral responsibility to neurosurgery as a society, I think, will increase by basically what are basically types of surgeries, etc., and behavioral change. I think that basically would be appropriate, because I think that it also isn't out of question that for example, if you're a citizen of North Korea, that you get your chip implanted to basically trigger some behavioral constraints, if that's what basically maybe the political goal may be in that particular region. So I think that the capability that I think will be introduced through neurosurgery to basically behavioral management, I think, are going to also be quite mind-boggling, and also a great responsibility. If you look at what's going to happen in the next 10 years, then I definitely see that coming as well.
Thanks a lot, Marcel.
Thank you very much, Stefan, Jorge. Fantastic presentation, simply mind-blowing. I was having two questions, but I was told that I should stick to one, which I will keep it like as a visionary question to both of you. First of all, I mean, what we can see over the last month is a lot of discussion about and around artificial intelligence, which is getting smarter than us. It is drawing, it is creating songs and poetry. How much do you see of artificial intelligence being considered in the development of the equipment by your companies? Sorry, it's a bit tricky one.
Okay, so perhaps I start. So first of all, it's highly regulated, and the different regulations don't really, fit together. In Europe, the MDR is applicable, which has been written in 2014, before really artificial intelligence was on the radar. So basically, the notified bodies are coming up with their own, standards and how that's being governed. There's an AI Act that's proposed by the European Commission that actually is regulated very different and actually is in conflict with the MDR. Then there's the European Health Data Space and the Data Act that basically forces companies to share data, that you can develop better AI components. However, the AI Act requires that for a medical device, 100% of the data has to be validated, which is impossible to generate large data points. So if you look at all the different acts that are basically being imposed by the European community, they don't really fit together, and they don't really allow us to basically achieve those goals. So independent from that constraint, I personally think that the latest generation of AI will tremendously, change healthcare. I think the first part will be that it really changes the patient-physician interview. The question is, what questions do we ask, what examinations, etc., and how do you basically orchestrate a conversation with the patient? I think will be quite different. How we can actually mine and assess basically the state of the art, and the condition is going to change. I think that basically so for providing better access to knowledge, I think it would be very, very quickly accessible to basically allow instruments to do more autonomous treatments. I think I see that still quite far, or at least further away. So the first application will really be in basically revolutionizing the physician-patient interaction, I would say.
Okay.
Jorge,
regarding one of the previous questions, just to confirm that ultrasound could be used for registration process in order to avoid X-ray exposure in the operating room, and also when we have been talking about bone resection, ultrasounds allow you to see further. So as Stefan mentioned about the haptic that you need to feel, at the same time, with ultrasound, you could see like 1 centimeter farther, deeper. So that's very, very important. And regarding to Marcel, to your questions, about artificial intelligence, what is the real challenge is how to train artificial intelligence. So right now, for example, with ChatGPT, you could say, oh, this is a good poetry, or this is something good or not. So there are people that is training. Have you tried any advisor for investment? People is training badly in order to other people could get advantage. So in medicine has to be something different. What is important is the training. In this case, the artificial intelligence that we use has confirmed with the result of the surgeon that has been using the robot. So you have to be sure that the data is accurate. So that's the most important thing, how you train the algorithm for artificial intelligence.
Thanks to all of course, the speakers and participants. I'll leave the word to Nikolai for conclusions.
Microphone.
Nikolai, you are off.
Sorry, thank you. Thank you very much, Enrico. Yes, we are close to the end of this very interesting webinar, but there is a question that I think is very important, and because the answer can contain an important message, and I'll ask you this question to both speakers, but please, if possible, a short answer. So this is the question from Christian Artopoulos. Nearly every hospital in Europe is losing money. How to find money to buy, to use, and to maintain these expensive tools? So please, Jorge.
Yeah, we have to change the business model also in our companies. Instead of one investment, probably we should move to renting, pay-per-use, or analyze other ways that could support this. But also, if you analyze the result of how to, the time that you reduce the surgery, the surgeries that the resurgery that you avoid with the robotics or things like that is cost effective. So analyzing the numbers is like these systems are cost effective, but at the same time, how it's very expensive, we need to modify to probably renting or pay-per-use business model. Thank you.
Stefan?
Okay, I think that, maybe the medtech industry didn't have its Tesla moment yet. I think that most of the medical companies are still somewhat, more or less caught in an old business model. So if you look at the example of spinal surgery, maybe, say 20 years ago, you had basically herniated disc and spinal fusion. Today, you have basically a dozen different procedures, 5 different approaches, different tools, etc. So it's like much more fragmented. Yet, medical technology basically more or less requires you to have one device to do this single-digit type of procedure, and a different device to do the next procedure, and another device to do something else. And so basically every hospital has a whole cabinet of different basically devices that are not talking to each other. So essentially a lot of the large medical companies think that they are basically large enough so that they are trying to create their own closed ecosystem that's only compatible to itself. And this is, in my opinion, an unsustainable, concept, and it's working against the Green Deal, sustainability, and basically also a modern framework. So to take a undifferentiated product and basically trying to use software to look up this in a silo or in a closed environment is basically doing a disservice to the idea of software, which is really driven by interoperability, by scalability, and being used in a very broad sense. And I really think that there should also be a push by an organization like ENS to force interoperability and basically ensure that this device is working with this software and this imaging device is supporting that instrument set, etc. And I think that this is really something that fundamentally should change, and that will also make technology a lot more affordable. And then also to separate the hardware from the software use. So today, the business model of most companies is to take this piece of equipment and every 5 years or 10 years or whatever, basically replace it through exact the same thing, just the next generation. However, if you look at maybe a computer needs to be replaced every 3 to 5 years, but a screen maybe every 8 years. But basically, I think you should basically use technology and hardware as long as it can. It's the long as the useful life of that is, and software should be basically a very flexible, continuous use. So I think that this is a concept of the circular economy, and by using resources more wisely, I think that also technology will become more affordable. But also I think we need to basically get more data to basically push for a value-based healthcare. So basically I think that also the payers are more willing to pay for a particular procedure if basically neurosurgery as a small subspecialty has better data to prove if a particular treatment is relevant for that patient. And then, of course, that will also define how much money can be paid to the technology provider for then enabling that treatment, and whether a particular piece of technology is improving a treatment, I think also has to be underpinned with data, and that will drive what a technology should be allowed to cost.
Thank you very much, Stefan. I think that this was a very important question, and probably we can make a webinar in the future concerning the financial models of developing different innovations, of introducing them to the market, and of course the questions for sustainability and how to progress further. Thank you very much. It was very interesting, really. Both speakers, it was a great pleasure for us to have you in our webinar. Thank you, Stefan. Thank you, Jorge. Thank you also to the co-moderator and all the attendees. We had a great interest as far as I can see the numbers. So we will have our next webinar in 2 months. We will, of course, be informed. By the way, I'm using the situation to inform you that we have established a LinkedIn group. It is the name of Emerging Technologies and Innovation in neurosurgery. So please join us there, be active there, because we are looking to enlarge our network. I think that the topic that we discussed are quite interesting, so you are welcome. Thanks to all of you, and till very soon. Thank you.